start with you, Kathy. If you would provide a 3 to 5 minute overview of your career in the aging services field. And Kathy, if you want to start.
This will be really quick. So
You want to use the mic?
this will
Be really quick. I might even not even take up the 3 to 5 minutes. My history and experience with aging is I started back in 1990 as a consultant for the Area Agency on Aging, just to consult on the nutrition programs. I owned my own business, and I closed my own business, and I was looking for employment, and the director came looking for me and asked if I would be interested in being a consultant for their nutrition programs. That's the home delivered meal and the congregate meal program. And I said, of course. So I took that on, never thinking about working with older adults, never crossed my mind. But I mean, within a few years of, not even that long, a couple weeks of working with the population, I just fell in love with it. And working with the area agency and the providers that provide the meals was really rich and really good. And my experience, I came out of working with the food industry. So I had a little bit of experience and knew a little bit about nutrition. So that worked out well. Well, as time went by, people left the area agency and positions opened, and I became a care management director. I wrote the grant for the Michigan Waiver Program. I became the assistant director, and then the director retired, and I applied for the position and became the executive, the CEO. So that's really it in a nutshell. It's 28 years later. It's just been a labor of love. I just enjoyed it, working with the people in Michigan and in my area, in the Flint, Genesee, and Pierre County areas. But even more so across the nation, working with, I'm going to tear up talking about Billie because she's my favorite. You too, Ron. But being able to work with all of the organizations seated here at the table has been really rich and satisfying. While I was director or CEO at Valley, I served on the board of directors for the National Association of Area Agencies on Aging, serving as treasurer, or secretary, then treasurer. Then lo and behold, the board chair position opened up, and I said, well, shoot, I'm just going to go ahead and apply for it. What can happen? And I did, and I was voted in. So I served as the chairperson, or the president of the board, from 2016 to 2018. And thereafter, when my term was up, I retired. And I retired in 2018 from Valley Area Agency on Aging, and I have not stopped volunteering and working still with aging organizations. Nationally, I was working with another national organization and still working with a lot of local organizations that deal with the aging population in my area.
Is there one of those local organizations you might want to reference here for this group?
Oh, I do sit on, I serve on the board for McFarland Home, Charitable Corporation. I've been there for, I can never remember how long I've been there, but it's been a while, serving as, just coming in as a board member, and as I was the CEO, I served on the board, and then, and now I'm serving as the chair of that board, so that's another satisfying part of working with this population for me.
Thank you, Kathy. Ron?
Yeah, first and foremost, I'd just like to say thank you, Roger, for having us tonight and having me. And it's an honor to be here with Mrs. J. And I call her Mrs. J, and you'll know in a why in a minute. And also with Kathy. And I have to say that 1990 was a vintage year. That was a vintage year. And it was a vintage year because that was the year in which Mrs. Johnson actually hired me to work at the Toledo AAA. And that's where my journey started, but that's all where I say, well, as far as my professional blessings, that's where that started. Also, is being able to work with her, learn from her, and grow with her, and also doing just some fabulous things. And we did so much great things that I got an invitation to go to Florida and to serve as the statewide director of community-based services. And I recall I was so what I would say, confused or uncertain as related to whether I wanted to make that move. And I said, you know, hey, Mrs. J, I don't know if I'm gonna do it. And she said, no, I'm gonna push you out of this. I'm gonna push you out of this house. And she said, well, but if it doesn't work, you always got a home to come back. And so that gave me the confidence just to really go out and to just to pursue my professional career. So I spent 12 years with Mrs. J in Toledo at the Toledo AAA. And I moved on to the Florida Department of Elder Affairs, in which I served in that capacity. And I had always thought that if you could work in Florida as far as older aging services, that was the mecca, that was going to be the greatest training grounds, and it was. And so, and I learned a great deal in regards to the politics, policy making, program development, as from a state perspective. And, but you know, when you work in the state government at a particular level, you have a short lifespan. So after, 5 years there, I had the opportunity to move on, in which I joined the U.S. Administration on Aging. And so I worked at the federal level for about 12, 13 years, and I actually loved it. And it was a great experience, a great opportunity, and I worked with the majority of the states that were on the eastern seaboard, along that was down south, and so got to learn different practices and how things were being interpreted based upon Republican, Democrat, Independent, or budgets and the like. And so one day, you know, Mrs. J and I, we kept in regular communications. So one day I, you know, called her up and we're talking. And she said, "You ready to come back home?" And I said, "Not really. I like it a lot." I like it. I like it. And so I was like, well, what you talking about? And she said, there's an opportunity here in Detroit that I think that you would be perfect for. And if you're interested, I'll make certain that they get your name. And so lo and behold, it's amazing how the good Lord works, but I never thought that I would come back or be back in the Midwest, but here I am. And the ironic part about it is that Paul Bridgewater, which all of you know, was my predecessor, and I met Paul in 1990 in Billie Johnson's office, and we kind of joke about how it's come full circle. So that's my story, and I'm sticking with it, and that's it.
Well, first of all, it's such a pleasure to be here with all of you. And Roger, you know, he doesn't know this, but he's been a mentor of mine for a long time. I've watched this man and have learned so much from him and from the PVM board members. So thanks to all of you for keeping us excited about this field of aging. I started in the field of aging in the early 70s, shortly after the Older Americans Act of 1965 was amended, which created area agencies on aging. I happened to be working for a United Way agency, and so the United Way director said to me, "Billie, do you think you can write a grant so maybe we can get some of this money and start an agency on aging?" Well, I was a planner for the United Way agency at the time, and I decided, well, if I'm going to write this grant, I'm going to write myself a job in here as well. I wasn't making very much money with United Way, so I put my application together and put a job in there for myself, hoping that the state of Ohio would fund our grant. And at that particular time, the United Way agency was very prominent in the Toledo-Lucas County area, in fact, in 4 counties. And my executive director said to me, "You don't know very much about aging. I'm going to send you to the University of Michigan to their School of Social Work and their gerontology program, and you're going to get prepped. And while you're there, I want you to interview a young man who I think might be a great executive director for this new agency that we're putting together." So I actually interviewed and selected my my executive director in the field of aging, I wasn't the first director, he was the first director, came out of the School of Social Work. And those of you who know Dr. Harold Johnson, who ran the School of Social Work at that time, Dr. Harold Johnson got a small grant from the U.S. Department of Aging, Administration on Aging, and invited newbies from around the country who wanted to move into the field of aging. And so we all spent most of the summer at the University of Michigan learning about this population and learning about how to expand services, programs, and resources throughout the country. So I kind of fell into this job and also wrote myself a job in this job. And, you know, but as I reflect, I actually feel that this position was a calling of mine. I was reared by my grandmother, and I used to hang out with my grandmother and all of her friends and listen to their stories. I listened to all of the things that their challenges, all of the problems they had in growing old in a largely rural community. And I just grew from all of that, and as I reflected later in life, I know that was the prep for my calling. I had a great grandmother, actually was blessed to know not only my grandmother, but my great grandmother, and I had a very short life experience with my great great grandmother. So I know this was truly a calling, Dr. Prue. It's, you know, things like that happen. And so I fell into the position, but I grew to love the job, and I always thought of what would my grandmother and her friends like? How can I develop programs, resources, and services that might meet their needs? So that's my story, and I want to say that I'm so proud of my mentees here. I have several around the country, but these two have been exceptional. So thank you for having us.
Thank you very much, Billie, Ron, and Kathy. So Kathy, you mentioned what's now called U.S. Aging, that used to be called N4A. Can you describe what U.S. Aging is all about, kind of what roles they play? You certainly had a vantage point as the chair of that group.
Well, U.S. Aging is, have they changed their name? You were right, it was N4A, all I knew the whole time I've been in aging. It's always been N4A, and I think they changed it right after I retired to U.S. Aging. But it's really, it exists, N4A or U.S. Aging exists to support the area agencies across the country at a national level. Their job is really to advocate on our behalf at the national level for funding and programs, and also to create training opportunities for area agencies across the country. So they exist to provide support for area agencies across the country, but at a national level. They are, you know, in serving on that board, it was just eye-opening on some of the things that they were doing nationally and have done. One of the things that they're proud of, they're proud of many things that they've done for area agencies, but way back when in the establishment of the National Association or U.S. Aging was that they created a elder care locator, and that's the telephone service program that they offer. And a lot of times people would not know where to call to get, they didn't know to call their local area agency, they didn't know to call the state or whatever, but they knew how to get a hold of a local elder care locator, the telephone number, and they would call. And little did they know that that locator, then once they make the calls to them and they have a question that's more local to them, they forward the call back to the local area agency on aging. So we still were able to get in touch with those individuals that needed help. But that elder care locator, you've heard of the you've seen the commercials on TV where it's the used to be a star. I can't remember her name. She comes on about Home for Mom. You've seen those, if you need a home for mom, you can call this number. Well, when you call that number, it shuttles those people over to the elder care locator, who shuttles those people down to the Area Agency on Aging network. And so when you think you're calling Home for Mom, you're really calling us. And the National Association has been instrumental in creating programs to assist area agencies to learn, to grow. When you've seen one area agency on aging, you have seen one area agency on aging. Not all of us are the same. And, some of them are very small and don't have staff or the ability to write grants and do some of the advocacy efforts that necessary to keep afloat. But and that's where the National Association can come in handy. They can provide help with grant writing and teaching you how to write grants and doing all of those things that as an area agency you really don't have time because you're in the trenches trying to get the work done. But the National Association is really there on Capitol Hill fighting for funding for area agencies day in and day out. So they are at the national level to really advocate and support area agencies at the local level.
Thank you, Kathy. Ron, you talked about having worked at the federal, state, and regional levels. That's tremendous perspectives that you've had. Could you just talk with us a little bit about how you've seen those three levels of government working together around aging issues?
Yeah, as Kathy was speaking, and Kathy may not even remember this, but we used to really respond to disasters. And as far as in the southern part of the country, it was really as related to tornadoes, ice storms, and floods and things of that nature. Well, Flint had just recently been through their water crisis. And we had called you, Kathy, and asked you to present to share your best practices with a number of states. And so the Valley AAA coordinated or worked, you recall that? And so we coordinated with the Valley AAA that was up here in Michigan to work with states that were down south and also on the eastern coast to talk about best practices in public health issues around disasters and emergency preparedness and things. And so I would say that at this particular point in time, the collaboration has continued to evolve and continue to grow. And I would say that we're right now probably in the golden era of collaboration. And if you ask me why we're in the golden era of collaboration, I would have to offer in regards to that we have several headwinds and several pressures that is forcing such. And that is you have a demographic tsunami as far as older adults, and then just the pressures that they're putting on various systems. And you also have the economic realities of trying to deal with the growing population of older adults. So it's kind of created what I would say some forced, it's given us some realities, and it's also given us some challenges, and it's given us some opportunities to really see how we're going to deal with this rapidly growing older population. So when you take a look at that and you see how, what I'll say is in 64, 65, when the Older Americans Act and Medicaid and Medicare was established, you had an insurance program as far as Medicaid and Medicare, and then you had social programs as far as Older Americans Act. And because of these, what I'll say as far as the demographic headwinds, we have come to see it intersect, where the insurance programs are starting to lean upon social programs to address some of the issues that our society is facing. And when we talk about the conversation that's come forward as related to the issues around social determinants of health and also health-related social needs, the reality has become that 70 to 80% of that medical care that these individuals are receiving actually occurs within the community. So it's reshaping or redefining a paradigm in regards to how medical care is actually being delivered. So that requires everybody to get to the table to talk about how we're going to address this issue. And that has created some synergies and some collaborations that I think, again, I think it just puts us in that era as far as the golden era of collaboration. And I provide you the example as in regards to, you take a look, CMS has just passed a rule, and it's their physician fee schedule rule. And this physician fee schedule rule essentially truly embraces the aspect of how payments are delivered. So instead of the previous fee for services, there's opportunities to create new codes for billing purposes, where community-based organizations can now bill in those areas. It's created where what I would say as far as caregiving training opportunities, and the thing about it is these caregiving training opportunities is not coming from the community-based setting. These caregiving training opportunities will be coming from doctors, and they will be training caregivers to provide that care for their loved ones in that community setting. When you take a look as far as some of the diabetes self-management programs, and just the way the shared values and the quality of care, it has really forced all of us to be in the sandbox and to play well together. So, to answer the question, Roger, I think it's the golden era of collaboration, and it's a great time.
Great. Thank you, Ron. So, Billie, almost 50 years at that one agency that you wrote yourself into the job, and it stuck, right?
It stuck.
49 years.
Yes.
Congratulations. So over that time, almost 5 decades, how did you see your agency evolve and change?
Well, when we first started out back in 1974, 73, 74, I had no idea that we would evolve into the kind of organization and area agencies on aging would play the kind of roles that they are playing now throughout the country. I just didn't have that vision, but throughout those years, I realized that we had to step up, and we had to be more than just an agency on aging. We had to, as Ron and Kathy have both alluded to, we had to find ways to collaborate with others. And so over those 5 decades, I learned very quickly that I had to work with people that I liked, people that I didn't like, people that could help me, people who I wanted to help me and had to convince them to help me. So, today, I retired in June of this year. And before I retired, I had established 5 different contracts with managed care organizations for our agency. And because of something that Ron said earlier, the whole medical system is reshaping, and the way you're providing and delivering services is changing so rapidly. But I knew that as an area agency on aging, we had to either learn to collaborate with these different managed care organizations, or we would be sitting on the sideline. So I wanted a seat at the table, and today we have contracts with Aetna, with Buckeye, who is also Centene, with Anthem, with CareSource, and with Medical Mutual. Those are very complex contracts. I had to negotiate those contracts to make sure they're at-risk contracts. So you have to make sure that you don't expose yourself financially, that you can manage these contracts and deliver the services, because suddenly you have customers that you never had before. So I saw the agency evolve in that respect. I also saw us evolve into areas like housing and long-term care. So I had to get in that sandbox, as Ron always says, and play with people that I didn't know. We had to learn how to speak medicalese, and they had to learn how to speak social services and human services as well. So we managed to get the collaborations that were needed in Northwest Ohio. I just think I had a fantastic board of directors who had some vision and provided me with the support that I needed to evolve over those 5 decades and play those roles. I started out with a very prestigious board of directors. Some of you know the Stranahan family in the Toledo area from Champion Sparkplug. Spark plugs used to be, they don't make spark plugs anymore, I don't think. But anyway, that family made its money off of that. We were blessed to have the support of the Stranahans. Pat Stranahan was my first lawyer and original incorporator once we spun off from the United Way agency and became our single purpose sole source agency on aging. And also had the support of local government, all the mayors, the county commissioners, et cetera, just brought together as many people as well as the community-based organizations. And with my background with United Way, they already had developed great community relations, so I was able to incorporate those as we evolved over those decades. And then, well, let me just say this. I started out with 4 people in our agency after I wrote myself into that agency. 4 people with a budget about $200,000. When I left in June, we were pretty close to $40 million, 3 subsidiary corporations, and nearly 200 individuals. So over that period of time, we evolved and moved into areas that we never, ever had the vision for. And certainly the Older Americans Act kind of wrote some broad goals and objectives, but I don't think the act itself and the legislation even realized what area agencies on aging could do and how it could play a major role in service delivery and quality care for older adults as long as we work with other people, as long as we work with other organizations and agencies.
Thank you, Billie. We're going to do one more round of questions, and then after these next 3 questions, we will open up the mic for any of the board members. We have some other questions, though, but I'm hoping that you've got some questions. So, Kathy, Valley Area Agency on Aging administers the Medicaid waiver program across, I think, 3 counties. Can you talk with us a little bit about what does that mean to administer the Medicaid waiver program?
Well, to answer that, I need to kind of go back to say and talk about a little bit about when I first joined the Area Agency on Aging. It was more, all we were doing was providing nutrition, home delivered meals and congregate meals. We did case management or care management for people who had a real need for in-home services and things like that, but it was very, 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 very small. Very small. There was no vision to it. I just thought, how is this going to be sustainable over the course of these years? Then we would always advocate as area agencies statewide that there needs to be something where we would catch those people that fall between the cracks. The people that maybe make too much for the care management program or whatever program they were applying for, but yet not enough to be considered poor enough for Medicaid. And so we were losing people between the cracks. They were falling between the cracks. These are the people that weren't receiving services. And so when it was revealed to us that the state is expanding or creating a Medicaid waiver program, which did that, it bridged that gap for those individuals to maybe earn a significant amount of money, I say significant, significant for the program, to earn those dollars, but yet still qualify for the My Choice Waiver Program. And I wrote the grant for that, and I remember writing it and toiling over it and thinking, oh, have we priced ourselves out? Are we doing this right or wrong? Ooh, if we don't get this, what'll happen? It was just nerve-wracking. And we did finish it. I made lots of calls. Again, my agency was not innovative at all prior to that. We didn't look past doing what we're doing, funding senior centers, doing small things like that. So there was no innovation to call upon to write this grant. So we really had to think through what we wanted it to look like and how it should look like once it was written and we were able to implement it. And so I remember writing the grant, and I drove it down to Lansing. I said, I don't want it to get lost in the mail. I don't want somebody to say, no, we didn't. I don't think we received that. And I said, oh, no, I'm taking this right down here. I want a receipt. I laid my hands on it, prayed over it before I left the place because I wanted to make sure we got that grant. And lo and behold, we did. And it was very difficult to implement because we had to start from scratch. We had no nurses, no nothing, no one on staff to do anything like that. So to implement it, to write it's one thing. To implement it was a whole different kettle of fish. Now we create a service provider network. I mean, it was huge for us, at least for our area agency. And but hiring nurses and hiring social workers left and right, really no training, so to speak of. You know, you relied on the fact that they knew their job as a social worker and a nurse, but we were writing policy and that as we were hiring people because it happened so quick. And I mean the money came quick after the grants were approved statewide for us at least. And I remember going down to Detroit and asking Paul and his staff, somebody help me with what this language is. And I remember I had to go and ask people questions on how to be prepared and how to write the proposal for the state. And so after it was written and we were successful in receiving it, that changed the trajectory of the area agency, at least Valley Area Agency on Aging, forever. I mean, that changed in terms of budget, money, funding, risk, all of it. It just changed the trajectory of it and really put us in a better position to be more of an asset and a benefit to the greater community separate from the My Choice Waiver Program. So I will say the My Choice Waiver Program really is a savior to area agencies, I think, in the Flint, because it opened the door to other opportunities for us to apply for, like the Care Transitions program that came along after that. So it was a big change, it changed the trajectory of most of the area agencies, I would say, in the state of Michigan once that program was up and running.
And Kathy, about how many individuals are served right now in that waiver program in Valley?
Oh, gosh. You know, I really don't know per se. I wouldn't even want to guess that. I'm not sure how many people are being served.
What year are you talking about? When did that start? When did you write the grant?
The grant was written right around in 2005, 2006, maybe somewhere in there. I may be off some date, some time. I don't recall specifically which year it was. It's just a blur because once it happened, it.
So Ron, the Detroit Area Agency on Aging issued this groundbreaking report a long time ago, called "Dying Before Their Time," and then I think it's been updated once or twice. Can you share at a high level what that report kind of found and what has happened as a result of that?
The Dying Before Their Time report is a report that I would say was really before its time. As a society and as a community overall, we're starting to address social determinants of health, and those are the buzzwords and things of that nature. But my predecessor, Paul Bridgewater, he had the foresight to really try to figure out in regards to what was occurring as far as the loss of population in the Detroit area. And, you know, there was just a general thought that it was an out-migration. People were just moving out. And that's a phenomenon which we're still seeing today in some respects. But there was something else that when he started working with Wayne State University as far as their School of Medicine, that when they commissioned the report in 2000, they came back with some information that proved to be truly what we say it was startling. And it was startling from the perspective that older adults, especially from the age cohort of 50 and up, they were dying before their time. And they were dying before their time based upon, you know, is well known now in regards to where the zip code in which you live in determines your life expectancy. And it really spoke about that the zip code in which our folks were living in was impacting their life expectancy. And it was, you know, for example, like if you reside in Midtown Detroit, your life expectancy is 13 years less than if you reside in Grosse Pointe. And so it was just a matter of 7 and 8 miles, and you had those variables. So at the high level, the Dying Before Their Time report reflected that our community, it was underrepresented as related to healthcare facilities, and there was a we were designated as far as HRSA, that we would be considered a medically underserved area. But in addition to that, what it really discovered is that there was an epidemic of chronic illness that our community was dealing with. And so within our service area, as far as Detroit, Hamtramck, Highland Park, Harper Woods, along with the 5 Grosse Pointes, we have about 150,000 individuals that are 60 years and older. And of that population, 90% had at least one chronic illness. So you could say that's acceptable, that's fine. We all gonna deal with Uncle Arthur, or we all gonna deal with maybe diabetes or something of that nature. But really what kind of drove the issue home is that 40%, or up to 60,000 of our population, 60,000 folks in our population, was dealing with 3 or more chronic illnesses at one particular point in time. And so it really reveals that we had an epidemic of what I would say of morbidity that was taking place in our community. So as Roger alluded to, the Dying Before Their Time report became our North Star. It became our mission, our calling, and at that particular point in time, and it still serves as our North Star today. And so we have done some things in regards to really embracing evidence-based programming to address like diabetes self-management, or to address falls prevention, or kidneys, and just medically doing things as far as meals preparation and working in that space. And we've also really started to embrace in regards to programs and services to assist individuals within their homes. Because we're looking at some of these social determinants of health as related to access to care was a big issue. Well, if you can't get to the services, how can we get the services to you? So we really started, and an example of that is with this COVID vaccination program, we probably provided vaccinations to, I would say, over 2,100 individuals that were homebound. They could not get to one of these drive-by vaccination shops. And we took the vaccine to them to provide the vaccination. So evidence-based programs, home-based primary care services, telehealth programs, we have really tried to evolve to reduce the access issue for our constituents.
How would you react to that if somebody says, all you do is, and not to minimize it, but you're only serving low-income seniors?
So that's true. Many people have that perception. Is this my many people have that perception. When I first decided that we needed to go for a levy, a millage in Lucas County to help supplement some of the federal, state, and other local United Way dollars to provide direct services, we thought we would run into this issue that the vast majority of citizens or residents would not pass a tax because of their perception that the tax would be just for low-income people. And it was just the opposite. The first levy we passed was in 1991, and it passed by almost 90%, which meant that the citizens understood. Unfortunately, that myth was just that, a myth, that they perceived the Area Agency on Aging as providing comprehensive, well-coordinated services for all people in the community. Now, it's true that not everybody needs your services. So with what we've done is we've drawn upon volunteers to come in and to help other older citizens receive the home-delivered meals, drive the vans if necessary, provide just a myriad of services to older adults, and they get connected to the system. So when they need services for their elder loved ones, for their parents, they know the kinds of services that can be delivered from an area agency on aging. So we tried to do that education. Actually, we reached down into the elementary and the high schools now, and working with the Toledo superintendent. He's very creative, and he has helped us develop services and educational programs for the students in the high schools, so that they can know if their grandparent or their parent needs a variety of services and programs. They know where to go, they know who to call. So it's a huge educational process. But we have to constantly fight that myth, because some people still believe that, well, it's government and I don't want to participate in any kind of government services. The fact is, we have 5, 6 different sources of funding, including a shared cost program. So a lot of people who get services from the Area Agency on Aging, from the nurses and the social workers, they actually share in the cost of those services and programs. So it's not all free, but for those who need it, we do not deny services because they don't have the ability to pay.
Thank you, Billie. And we'll open it up for questions. Mark. Okay, Tom Jankowski.
So my question is this, because I've seen it from both sides, and Billie, you talked about playing in the sandbox. Even the biggest AAA in Michigan, which is Region 1B, covers 6 counties, is dwarfed by the smallest health system in Michigan. And how do you play in a sandbox with an 800-pound gorilla without getting smashed?
That is a challenge, no question about it. It's a great question. In my particular region, ProMedica was the 100-pound gorilla, and you know, we had a challenge. I wanted to get a PACE program started, and I knew that in order to do that, I needed to develop partners, and one partner had to be a health system. And working with ProMedica, and of course they're now having their own financial challenges, but prior to that, when they really were not, I developed individual relationships. I really, I think it's been a gift for me to just deal one-on-one with individuals. I got to know the president and the president really well. I happened to serve on the art museum board with him. I did art museum business, but I also did business for our agency and cultivated that relationship. Relationships are so important when you're trying to provide services and you're trying to help individuals, because without them, the trust isn't built, the alliances can't be formed. So I've just taken that on, and I've tried to teach my mentees how to do the same thing, how to build and cultivate those relationships, because they'll take you a long way, and they will help you reach your goals and objectives, and to stay focused on those things.
I can hitchhike on that as well. One of the things, working with the insurance company is one thing. That's a huge undertaking. But also working with the hospital systems was a whole nother kettle of fish. And when CMS put that grant out for care transitions, and that's to keep people from going back into the hospital within so many days of discharge. And we then began working with hospital systems. I mean to tell you, it was eye-opening for them, and it was for us as well. Hospitals, I didn't feel that they really recognized what happened to their patients once they crossed that threshold and went back to their homes. They had no idea why this person keeps coming back. They were dumbfounded. Why does this person keep coming back? We're not getting paid and for these repeat visits, and why is it, why, well, the person doesn't have air conditioning and they have COPD, or, in their home. They really had no idea. So really, working with those hospitals was an eye-opener for them and for us, area agencies. And it helped them understand that there's a network out there that can be an extended arm to what they're, in other words, when we provided care transition services to some of their patients, the patients thought it was a hospital benefit. They did. They thought it was, oh, God, this is what I get now when I come home from the hospital. And so they thought it was a hospital benefit, and they loved it. They loved it, and the hospital loved it. And we did make a difference in their lives and them going back and forth in and out of the hospital. But when the funding ran out, the hospitals all of a sudden couldn't find, long as someone was paying for it, they were good. Oh, we can expand that. As a matter of fact, they hired most of the people away from us that worked in the care transition program. So it was really good, but it was two-edged sword in that the insurance companies are huge and having to learn how to work with them, and the hospital systems are huge and having to learn to work with them. But it's been a journey. But you're right. It's for me to really get hospitals to understand what these individuals work with or deal with when they're home. I created Big Wheels Deliver Meals. And so I invited hospital CEOs and bank CEOs and to go out and deliver 5 or 6 meals in the community. And I was riding with the hospital CEO. So I made sure I rode with that hospital CEO. I said, come on, let's go out we'll deliver together. And we're delivering meals, and she says, oh, did you see they had to come down the steps with a walker and go back up with their meal? I said, yeah, that's it. Oh, and so after that, she made sure all her leadership team delivered meals so that they could at least see what's going on in the community. But that was the hook I put out, and that's the fish I caught, because I was able to do business with that hospital, actually 5 hospitals in my area, to deliver that care transition program. But that was the eye-opener, and I understand you're still having to deal with some of those hospital systems as well as insurance companies.
We are, and I'll just add on, piggyback to what Kathy and Mrs. Jake said. It is relational. And it can be transactional, and I think sometimes we approach things from a transactional perspective, and we cannot do that. And as Kathy was alluding to, as far as the culture, we have to understand their lingo, and we have to also educate and be able to express or to share what is the return on investment for being able to partner with a community-based organization. And what is the value that AAAs provide in regards to this ecosystem and in regards to service delivery? And so I think what's also occurring is that we're becoming a little bit more sophisticated. We're starting to learn how to articulate and to speak in that space. We still don't have it though, and a lot of it I would say comes down to I like to say data is currency. And we are still behind in some respects as related to the population health type of data, but we're catching up and we're starting to understand that a little bit more. But I think we're getting some assistance also because, as I alluded to a little bit earlier, you always follow the money. And what CMS is doing and how CMS is situating it in regards to value-based payments, and how they are incorporating and focusing upon quality scores as related to the satisfaction of members and things of that nature. That's our wheelhouse, that's our space, and that's how we put our foot into the game, and we'll be able to survive and be seen as far as a valuable partner. But what Mrs. Johnson and what Kathy alluded to and stated is very true. And we do have these Tyrannosaurus rexes per se that are kind of encroaching on or entering into what I'll say the senior market for economic reasons, and also for to enhance the lives of seniors also. But there's a role for all of us, and we just have to be able to articulate and to build those relationships to express and share what our value is in this equation.
I think there was another hand or two out there, Jim. Did you have your hand up, Jim Gompers, or no?
No, I'm good. Thank you.
Any, yes, Amy.
So I was very interested to sort of hear you talk about community health integration and other finalized items in the MPFS final rule. So I was just curious that given the headwinds, Ron, that you were talking about that you are all facing as an agency, what further policy developments would you like to see from CMS to help you sort of move into the tsunami, the demographic tsunami that you talked about?
Yeah, that's a great question. If I had my one wish, I would say, and I think President Biden, he put it out there in regards to his prioritization when he talked about what he wanted to accomplish, and one of it was for caregivers. When we take a look as far as some of the disparities and some of when I spoke about the access to care issues and things of that nature, I truly do believe that caregivers is that third leg of the stool in regards to closing that gap. And if we could find ways to be able to better support caregivers through tax breaks and or through the ability to receive reimbursements or from waiver programs and the like, I think that would really assist us in many, many ways.
Thank you. It's a great answer.
Yeah, looking into the future, where can we connect? I mean, where do the AAAs and the PVM connect? Besides having dinner together, which is nice, but there's a lot of services that need to be provided, and they're not going to be provided by just you, nor just us. So if relationships and collaborations are important, and you're sitting next to someone who loves every collaboration there is, and it's what we do. I mean, seriously, being serious, it is what we do. What can we do here? I mean, where can this go besides we've had a nice evening together?
First of all, we've got to come together and we've got to communicate. We've got to share because we are more aligned than we are not. And I have been working with Brio out of Michigan, United Methodist Retirement Center, and another long-term care facility, Otterbein, that's based in Toledo, Methodist-based organization, and National Church Residences to develop a PACE program. And I heard in the director's report tonight that there is an area agency involvement in some of the PACE development. PACE is a wonderful opportunity for us to bridge the gap and have a collaboration. We don't know, as area agencies on aging, how to run PACE programs. You do. We don't have expertise in housing. You do. Only a handful of us in the entire country have developed housing for older adults. The collaborative opportunities are just wide open. It's a matter of coming together, discussing what the needs are, looking at our various areas of expertise, and trying to formulate some plans and some new vision, because we're going to need it. As Ron said earlier, there's a lot of older adults out there, and our country is not ready for providing those services. We can't put them all in nursing homes. We can't continue to send them to the ERs and have them to return in a week or so. We've got to get smarter, and I think CMS is beginning to look at what those opportunities might be, but it has to go beyond CMS. It has to start at the local level, at the regional level, and at the state level. This collaborative activity, the collaborations, just must evolve if we are to address the future needs of our older citizens.
Ron or Kathy, anything to add to that question? Dr. Jeffries? You be next, Henry.
Thank you. Ron, you mentioned that groundbreaking work dying before their time, and I think that was initially done in 2000. I'm sure that's been revisited since that. Are there any areas where the disparities have improved? If not, what's getting in the way?
Yeah, that is a great question, and that was one of Dr. Jeffries. That was one of the disappointing facts, is in regards to that. The first report was completed in 2000, and the most recent one was completed in 2020. And over that period of time, there had been no improvements. And we estimate that probably that this has been an epidemic that has gone on, even probably going back to the mid-1900s, 1950s or so. So it's a long-term issue, and I think what's getting in the way is those social determinants of health. When you have the food insecurities, when you have the lack of transportation, or the lack of affordable housing in communities, until what I would say, we could collectively come together to come up with solutions. It's going to take the entire village to address that. And so it's an issue that we at DAAA realize that we can't address by ourselves, but we could be a convener, we can help be a collaborator and bring the government together, bring housing, bring school systems, utilities, and all, the environment, but it's all of us going to collectively have to come together to address it. So, that's going to be the big lift.
Ron, that's not just, that report didn't just include Detroit.
No.
It included Flint.
It included Flint, and I would say,
and Benton Harbor, so you can see the.
Yeah, and I would say that the beauty of it is that it is not just applicable to Detroit. You can go to probably any urban community and face or see the same issues, those disparities, yes.
Here's another one of my major concerns. I don't hear the religious community's role in all of this. It's one of the most powerful forces in our country is the church. But I don't hear any rallying cries for the church to really get involved in a systemic, where there's a common voice, common theme across the religion in this country that says, we have a stake in this too. We have a stake in our members not getting bounced between agencies and services. Who's calling that group, that body, to the fray, to the fight, really?
Yeah, that's a great question, Mr. Johnson. And what I would say is that from our perspective, the faith-based communities are the original social service organizations. Sure. They are the original social service organizations. And if we can build relationships and utilize, and I'll use the example of caregiving. That's the horse I rode in on. That's the horse I'm gonna ride out on. Mm-hmm. If we could get the ministries or to understand what caregiving is, and if we can teach and train them, our ability to multiply the outreach and the ability to multiply the extension of services to the community just grows exponentially. But as Kathy alluded to about the AAAs, when you deal with one AAA, you deal with one AAA. Yeah. When you deal with one church, you deal with one church. And so it's a process in regards to really try to cultivate and build those relationships and to engage them to understand the benefits for their members. But that's a community in which we work with in a number of areas, in a number of ways, and we're going to have to continue to work with them as we grow our services and programs.
I think you have to be careful about blanketly thinking churches aren't involved, because there's a lot of churches doing huge amounts of work, but are not like the AAAs or the PVMs. They just do the work. I mean, I will blow the horn for our church. We are in Detroit. Jefferson Avenue is in Detroit. We team up with an organization called Make Food Not Waste. They bring in thousands of pounds of fresh food to our professional kitchen. We have a chef. We feed at least probably 1,000 a month, sometimes more. We've been in Life magazine, National Geographic, about Detroit and about what we do. So we do it quietly, but we're feeding thousands of people in Detroit who come through our parking lot every Friday and get fresh food that's made in our kitchen, as well as teaching children how to read and doing all of those things. And we're not alone. I just happen to know about our church. We're not alone. It used to be that churches, of course, used to be in the housing business. They're trying to give us their housing now because the folks who did it are gone. But the problem, Henry, is the real problem is that Protestant churches are just dying. Can hardly, I was on the board of trustees of the Presbyterian for 9 years, chair of the board, and I couldn't sell churches fast enough to whomever. Bars, breweries, because they'd buy them. So that's just a general problem. So somebody has to step in. And the other thing is, this is just an opinion, the great church voices are pretty gone. I mean, the great pulpiteers who stood up and demanded, listen to me now, are kind of gone. We lost a pulpit giant, but there aren't many left. There were lots of them here in Detroit. I mean, giants. They're kind of gone. A lot of churches are more entertaining and don't think about social service work. By the way, I just want to say, was Margaret Davey still active, Ron, this is at Renaissance Towers when you came?
I'm not familiar with
Oh, good. You missed her. What a blessing. I consulted on the 9% tax credits and built the kitchen because she was feeding literally thousands of people out of that kitchen. But she was really something. But oh, by the way, one last thing. When I was the COO of Lutheran Social Services and Dying Before Their Time came out, we carved a wing out of Luther Manor because we were right on the boulevard there. And to facilitate, many of the needs that came out through dying before their time. Paul and I worked together. That's where I met Paul at that time. And Lutheran Social Services developed a great relationship with DAAA at that time. So anyway, little personal note.
Describe to me in Michigan the presence of the various agencies. Build me the quick picture. How many are there? Where are they?
16 area agencies in the state of Michigan. They're all across the state. There's an area agency that covers all, 82 counties and across the state. So
no matter where I live, I could.
Right. Correct. Wherever you live, there's an area agency that covers that area.
Roger can send us that map.
Yes, we've got
Last question, then we're going to take a 5-minute break. John has a question.
I had a question about trust and a lot of issues with medical care, government programs, or social services or something is getting them there and getting people access to them, but some people don't want to use them because they don't trust them. You know, women go to medical care and they don't get believed or something like that. Do you have thoughts on that subject and educational suggestions for how to remediate that?
It's not an easy thing to deal with. You just have to deliver what you say you can deliver. You have to work to keep your word. You have to have a good housekeeping seal in your community for seniors to trust you, for caregivers to trust you, for your community to trust you. It's something that we continuously work on so that people will access and come to us for services, programs, and resources. It's something I still consult with my area agency on aging in Toledo, and I just talked to the interim CEO yesterday about this subject and some things that he is going to now implement to help continue to build trust and relationships so people utilize the services.
So before we express our appreciation to Billie and Ron and Kathy, something to think about, and this goes back to when the Dying Before Their Time study first came out. And you know, I had thought there had been maybe some incremental improvement, but to hear Ron say there was really not much that changed in 20 years is very, very, very sad. Think about it. So I remember, so somebody, maybe it was somebody in Wayne State, they did the math and they said, if there was a jetliner that crashed and 300 people died, that would be a big deal, right? That would be on the front page of every newspaper, and 300 people died. The math works out that it would be like a jet crashing every day, day after day after day, for 20 years. And you don't see it on the front page. It's in the background, although it's certainly what Ron and Kathy and Billie and their staffs have worked hard and see it all the time, but we've got to lift that up because it's in 2023 to think about once the data's out there and 20 years goes by and there's no improvement. I mean, that's just unthinkable. And so we wait another 10 years, we wait another 20 years. Anyways, I don't mean to have us end on a downer note, but it's that important. I mean, it really is that important. So let's give a round of applause to Billie, Ron, and Kathy.